Good afternoon. It's Maggie. Oh my gosh, I just did the live. I was having some technical difficulties with my logo overtaking the whole screen. And I was on Facebook, and then I realized when I was done, I didn't check the go live. So I'm re recording this. I'm supposed to be somewhere, but I'm going to try to do this in 30 minutes. The title of this program, and if you watch the Facebook presentation, it probably going to go into more details as to the preface to why I'm doing this today, and what I'm thinking in terms of why we need to talk about this, the hydration CNA. This is my proposal, and at the end of the presentation, I did make an appeal to any facility who's willing to work with me on looking at their data pre-implementation, if they believe in the concept. And hi, I see somebody watching. Well, thank you. And then we can look at the data 6 months later to see if we see improvement in your rate of rehospitalization, the incidences of UTI and falls and pneumonia and all those. So I'm thinking we would look at those three. So having said that, the reason that I wanted to talk about the hydration CNA, as I said, it's because I have a pet peeve about mouth care, in addition to all the different complications that patients, residents can experience as a result of dehydration. But mouth care to me, which is something so basic, part of the ADLs, it gets so neglected, and the nursing shortage is making things worse. So I'm going to go through these slides a little bit fast because this is kind of a recording. I was supposed to record this when I did the live, and I realized, because otherwise you guys won't have anything to look at, right? Because I want to be able to post it, especially on those two sites on Facebook, those groups that showed some interest in the information. Okay. Let's see. I'm going to share my screen with the presentation. I have to go back to slide number 1. Again, this is Maggie Lazar. I am an advanced practice nurse, and this is Nurse Training and Advocacy, which is the name of my Facebook and YouTube channels. And this is where I post everything that I talk on these lives and other things. Sometimes midweek, I would come up with maybe a little teaser, a little something to kind of help you guys out. Because again, I am dedicated to, now that I'm retired, to providing some more training for you guys, because the issues that I see are so impactful. They impact our nurses and impact families. And then, DONs working the floor, the cart, and doing their jobs. Nobody should be doing multiple jobs. As I said, nursing is just part of your life. It should not take over your life, because eventually your health is going to suffer, your relationship is going to suffer, your family is going to suffer. And the advocacy part of this title that you're looking at is that I want you to learn to advocate for yourself. I see a beginning of it. Some nurses start saying, hey, I'm not going to do that. I can't work, 16 hours, 5 days straight. And there was a nurse who posted on one of those groups this week that she just got hired at a hospital, and she said she was on her 10th 16-hour shift. How do you even do that? How is that humanly possible? You putting yourselves up to make an error. And remember, as a nurse, your error could cost somebody their life, just like we've seen earlier this year about these two nurses, what fatalities. We cannot afford to do that. You're not a machine. Even a machine, you got to turn it off sometimes. Don't let anybody bully you or shame you into working so much that you don't know whether you're coming or going. You're delirious. That doesn't mean you care for your patients that much if you don't take time to take care of yourself. Okay. So dehydration, from what I'm the data that I look at, is causing a lot of issues. So my title is The Case for Implementing a Hydration CNA in Your Long-Term Care Facility. And this is going to be the title of my article that I'm writing. And hopefully it will get published and I'll be able to let you know how you can have access to it. But with any article that you write, at this level, you have to have data and there are technique, there are things that you need to do, if you send an article to be reviewed, it's peer reviewed. That means people who are your peers, professionals, are going to look at it to see, is it a valid case? Does she have a point? So I went in and looked at different studies that had looked at dehydration. The problem number one that we have is that there is no standardization definition, no standardized definition of dehydration. Okay. We know in long term care and in healthcare in general, what we talk about dehydration. Somebody whose skin turgor is so really thin, they really look bad. We know their intake is poor, but there are certain parameters we look at. We look at BUN and creatinine. We look at serum osmolality. We look at their intake and output. But again, we don't have a standard in the literature, in the medical community. There is no standard definition. And I look at articles from the US, an article from Australia, there was an article from Israel. So it's not like we just look, it's not an American problem. We in Canada, we have the same problem all over that, because, and I tell my students that when I teach, is that age is the number one risk factor that we have for cancer, heart disease, diabetes, mostly everything, right? So as you get older, you have a decrease in your renal function anyway. So if you were just looking at beer and creatinine, it may not be an accurate assessment of dehydration. So we need to have, a combination of factors that we're looking at, right? Maybe it's weight, maybe it's sodium level, maybe, so we have to come together as a medical community and decide, the scientists and researchers need to sit down and say, we need a standardized definition, just like we look at, the American Diabetic Association. We say, this is what we want the A1C to be. We want the fasting blood sugars to be this. We can do the same thing for dehydration. So that's one problem we don't have. And then in looking at the studies, everybody was looking, they're kind of throwing this kitchen sink at dehydration. It's like, okay, let's see how many interventions and what we can do to attack the problem, right? So that's what I looked at. So in looking at that data, it showed that up to 90% of re-hospitalization from long-term care are unplanned. Yeah, people go to long-term care to get well. If they're going to for rehab, they hopefully go home without having complications. How many of your rehab patients end up back in the hospital, right? Yeah, you could say it's because they discharge them early, but is it documented that that's why? A lot of them go for infection. A lot of them go back for UTI. A lot of them go back with pneumonia. So we're not trying to put blame on anybody. We just need to look at the data and look at the causes, make a correlation, and say, what do we need to do? 48 to 60% of adults hospitalized or in the community, that means at home, or in long-term care, or in assisted living, or in retirement homes, right? They show signs of dehydration. Adults, remember, age is the common denominator there. Because you're older, your taste buds are not working right. Food doesn't taste good. So if food doesn't taste good, drinks don't taste good. You just don't like to be bothered because things just are not appealing to you. So if you don't like certain things and you're just not feeling good and you have all these comorbidities, dehydration is just like lurking around the corner because you have all the making of waiting for something to happen, right? 20% of Medicare beneficiaries are re-hospitalized within 30 days. What is your rehab rate in your facility? Do you know that? Do you know how many of your residents, how many of your admissions end up back in the hospital within 30 days? And I know your bosses are looking at that data because it affects their reimbursement. Medicare, Big Daddy is looking down at this stuff, right? So we in building culture need to impart to our staff the importance of that. People can't work in silos. The CNAs need to understand the impact of dehydration on their patient. They need to understand, your nurses, your therapists need to understand that rehospitalization affects your facility, right? It affects satisfaction score. It affects your reimbursement. Okay. So you have got to be able to invest in educating your staff. Okay. The other thing I looked at is that it says people with dysphagia, your stroke patients who cannot swallow very well, they are even at a higher risk of dehydration because they don't like to eat the pureed food. You know that. They fight over that modified dysphagia 1 diet, whatever we call it, right? And then you're going to bring in water that is thickened. How appealing is that? Are they really open, say, oh yeah, let me gulp this down? I mean, I'm thinking about it, I'm like, ooh, right? So they are at a higher risk of dehydration because of the restrictions that they have with their diet and their liquid. And you also know that your staff, I remember that hydration cart in that facility I worked at, there was no ticket on it. You had to go to the kitchen and beg for your life to get some ticket. It's another video, right? Between the kitchen and your CNA staff. Oh my gosh, I used to deal with that all the time as a supervisor. So that CNA has to leave what she's doing, go to the kitchen and beg for a couple of packets of ticket to put it in the patient's liquid before they give it to it. How likely do you think it's going to be a daily occurrence that this CNA is going to be running to the kitchen to get it? They used to leave it in the kitchen, now the kitchen is under lock and key. It's just a lot of barriers. Dehydration is associated with longer hospital stays. We know that. It increase and also increased rates of rehospitalization. We already said that. In one research study, it says among all subjects at time of long-term care admission, the prevalence of low hydration or dehydration, we can use those terms interchangeably, was 60%, 60.5%. That means they are coming to your facility already dehydrated. Were they dehydrated because they were in the hospital, or were they dehydrated at home? Well, it might be a combination of both. Remember, age is a major contributor to dehydration. So by the time the patient comes to you, they're already dehydrated. But it says now, if they go back to the hospital within 30 days, their their hydration rate, dehydration rate goes up. So, which means by the time they come to you, they're already dehydrated. And by the time you send them back to the hospital, they're more dehydrated. So, do you think you have a problem? I would say you do. We do. So, a few research findings. So, the research not protocols, the research studies I looked at, it's like there were multiple ones. They were looking at different things. So what they're saying is, yes, we have a problem. Yes, we have people going back to the hospital. So now they're looking at what can we do to attack the problem. And again, there is no standard. No one is saying you need to do A, B, C, D. So everybody's like trying to do this today, and like anything in research, it takes time for everybody to kumbaya and come together and say, this is how we're going to do this. And because this topic, I don't believe, is getting the attention. It's not cardiovascular disease. It's not stroke. It's not cancer. It's not HIV. It's not COVID, right? So it's like under the surface, we know it's there. Well, yeah, they're old and feeble and, and they're kind of frail. They're going to be dehydrated. Just like we say, dementia is not a normal part of aging, being dehydrated should not be a normal part of getting older, right? So, what some of the study findings not findings, what they were doing. Some of them said, okay, let's offer fluid between meals, 10 o'clock, 2 o'clock, you pass fluid. Okay. Do you have that in your facility? Do you have somebody, all your CNAs doing that? Well, I guess if there are and your re-up rates are good, then you're not concerned, right? Um, Choice of drinks. Some facilities, well, the research, one of the implementation measures was they had like a drink menu where people had a choice of, let's say, Coke, Diet Pepsi, root beer, different kind of juices, which is the idea behind the hydration card in some facilities, right? Now, I've seen the family members go to that cart and get some stuff for the resident. I've seen the CNA go to the cart if the patient asks for something. Let's say they say, I don't want orange juice, I want cranberry juice. The cranberry juice was there. Or if the patient or the resident is ambulatory and able to make their own decision, they would come to the cart. But then you're thinking, are their hands clean? You go through all that stuff, right? But it was haphazard. It wasn't something that is done consistently. And just because you take a drink to and put it at the table doesn't mean they're going to drink it, right? How many times we get our trays returned to the kitchen with nothing was open? Or the CNA didn't even open the drink. A lot of them get coffee, right? But it needs to go beyond coffee. Some facilities said, we want to change the setting during mealtime, make it a happy atmosphere. We want the food to look nice. You eat with your eyes. Do you have all brown on that plate, or is there color on that plate? Do they have broccoli and carrots and cauliflower and rice and the chicken? If it's more colorful, the patient is more likely to eat. And some of the research findings said if a patient is more likely to eat, they're more likely to drink. Because, like I said before, your taste buds are down, you don't have any appetite, you're taking 10 different pills and it kills your appetite, you don't want to eat. And if you don't want to eat, why do you need a drink to wash it down? Okay? So keep that in mind. So some of them just made it like really colorful and popping and music and stuff like during mealtime. You could say you have a CNA who is assigned to the dining room, but is she assigned to make sure everybody gets their food, provide drink for whoever asked for it, or are they tasked to make sure people are actually hydrated? You need to answer that for yourself. What does your staff at mealtime do? What are they responsible for? Maybe you can start there, but that's only at mealtime. People need fluid more often than that. How often do you drink at home? And if you're working, yeah, like me, we don't take time to drink, which is bad. Some studies implemented using colorful silverware. They don't want to use that cheap silverware I see around, right? They had red, if like the modified silverware that some people use if they have like a brain injury and all that. They had them in red and yellow. So that was a measure that they implemented to see if that's what's going to, I guess, in a nutritional point of view, to encourage patients to eat if they have colorful silverware. Okay. Another intervention was using a cup rather than a straw. You know, if you follow your CNA, you're gonna see the moment they offering a drink, they pop a straw in that cup. Now, how many do all your patients use straws? Can your demented patient with dementia, sometimes they can even suck to the straw. So this particular study said we find that our patients did better drinking if we give it to them just a cup versus putting a straw. Something so simple. Don't stick a straw in everything. You can implement some of that in your facilities, right? Noted improvement in fluid intake when single measure is implemented. So what they're saying is when we try to throw the kitchen sink at a problem, they found that it didn't work as well versus implementing one intervention. And that's where I come in. I'm saying, let's just try hiring a hydration CNA, study it pre and post, and then see if it's worth it, right? So don't just say, oh, we're going to change the color of the silverware. Well, how about just putting that money towards the salary of one uh, hydration CNA? Because not everybody's going to use a silverware. Not everybody's going to be, oh my God, it's so pretty. How many of your residents will do that? Okay, so let's just think uh, concretely about, of course, your money and your resources are very important. So if you go into invest in something like this, you want to make sure it's worthwhile. Okay. Reversal back to pre-intervention. What the studies show is that, okay, we're going to do these things. We're going to offer fluid. We do it for a few weeks, and we compare when we were just implementing it. The viewing current was this, the ratio was this, the osmolality was this, and then as soon as they stop, the residents, their condition reverted to the original um, state, which means consistency is the key. And now you have shortage. You have a shortage of staff. So, okay, it's not going to work. You have to do it consistent. It's not a one-time thing. You can't say, well, if we implement this, maybe the patients are going to get in the habit and understand the importance of. You have to do it consistently. Okay. So some of the benefits of a proposed hydration CNA, which is my proposal. Okay, this is Maggie's proposal. I the literature, nowhere so far have I seen anybody implementing the hydration CNA. They want their staff to do this stuff in addition to everything else that they're doing, and they're failing at it miserably because of staff turnover, funding, shortage. Okay, just like culture. When I talk about culture, I say you have to see the importance of having it, the benefits of having it, and you have to be careful to monitor and nurture your culture, which is another one of my tagline. Nurturing your culture is your responsibility as a manager, as an ED, as a DON. You have to create an environment where that culture is lived out every day. If you say you care about your resident and you want to decrease your risk of fall, you want to decrease your rate of rehospitalization, hiring a hydration CNA is one intervention. I'm not saying it's the end of all. I'm not saying that it's going to solve all your problem. I'm not saying that nobody is going to go back to the hospital because of that. I don't have a crystal ball. I couldn't say that. You have a dynamic, so many people in your facility, so things are going to happen. This is just one measure. And the only way you're going to support the benefit of it is if you join me and let's do a research study and say, okay, we're going to see what our numbers were we're going to implement, and then we're going to look at our measures post. Can you imagine if we had really good benefit? You drop your rehospitalization, you decrease your number of falls, and then you present that to your regional, to your boss. There goes your bonus, right? And we can publish this. Then you get recognition, and you don't have to spend so much money on marketing because that's going to be a marketing tool. You're going to put it in all your marketing material, and everybody's going to know you're doing this thing, and therefore your patients are better. Nothing ventured, nothing gained. This is the whole concept of what the one I'm looking for? Evidence-based practice, right? As I said before, somebody said, not me, I'm repeating, I'm borrowing. Insanity is doing the same thing and expecting different results. We have been doing staffing and managing our patients the same way for decades. How's that working for you in this current environment? So if it's not working so well, why not try something else? And like I said, my case is one position, one CNA. And I realized that yes, we have 3 meals, but you can't work somebody 70 hours a week. So let's talk about how we can do this. You want to hire a CNA. You want somebody with some kind of medical knowledge. Probably somebody very mature, maybe who's been with your facility for a while, who understands after you don't want to take somebody from the street and who has no concept about dehydration and trying to kind of calm everything, right? Or maybe it's a seasoned CNA who is on light duty, who is maybe I don't want to say older. I don't want to be quoted as saying older people, older CNAs can't work. But maybe you've worked 20, 30 years and you're just kind of slowing down. That would be a great position for somebody nearing retirement, right? Actually, I would love to do that, but you're not going to pay me enough to do that. So all I can do is just give you the information and let you go at it. So it has to be a CNA. CNA is going to be present at mealtime. And again, my proposal is one CNA working 40 hours a week. So I would suggest you make it a salary position. Now, if somebody is so into they have to clock out at 3:15, you don't want that person doing this job. You want somebody with a little bit broader concept of this is a mission. This is somebody who's going to be invested in seeing your patients get better. It's not going to be easy to find someone like that, but if you invest in it, just as I said, you want to hire responsibly, even for this position. You got to make sure you have the right person. Okay. So, my suggestion, my proposal is that, you know, because you have 7 days a week, now the weekend, you can rotate that person on the weekend as well. What you want to do, maybe you do 2 days or 3 days. That person work Monday, 7 to 3:30. That means she's present for breakfast and lunch. And then the rest of the week, you want her to do lunch and dinner. That way she is seeing a variety of patients at different times. Okay. Now, it's not going to be for every resident because not every resident has that issue. But the ones who are at risk, you can pull a report and you see whose labs qualify, who's at risk for a high urine creatinine, who's got a high serum osmolality. You got to get your physician, your providers on board for them to order this test for you. They do pre-albumin and all that, but do a serum osmolality so you could see how concentrated the urine is. You already have your BNP. You already know what the sodium is, right? So if you identify patients who are at risk, they're just poor eaters, you having to do dietary should be involved in this because this person is going to work really closely with dietary to see what are the dietary restrictions, who's at risk for malnutrition. Those are your people you want her to focus on. Who is on a modified diet, who's on modified fluid, intake and taking liquids. You want that person to work with your dietitian really closely, right? So you're going to have increase your compliance with dietary and food restriction. I told you before, I've seen that beautiful cart there with all the drinks and the ice. Yeah, the ice bucket gets used a lot, but the drinks not so much unless a family member wants it. And the list of patient restriction is supposed to be posted on there. 90% of the time it wasn't. There was nothing, no instruction as to who's on thickened liquid. So who's NPO, right? Okay, so you're going to increase your compliance in that area. You want flexible scheduling. Again, you don't want somebody who's got little kids at home who has to pick them up from daycare. It may not be a perfect position for someone like that. You want somebody who has flexibility, who can work those hours that I talked about, and who has a heart for this topic, right? So you're going to have improved hydration status. That's my proposal. That's what I'm expecting to happen. You're going to have improved mouth care. I already told you that's a pet peeve of mine. Your mouth breathers, your people who are on peg feedings need attention to their mouth care. So that CNA would be really involved in that. You're going to have improved resident family satisfaction. If a family member knows, oh, she's the hydration lady or gentleman, and she's worried about my mama getting her drink, she makes sure she gives mama the drinks that she likes, right? Not everybody likes water, but it's better to give her tea than for her not to drink anything. I'm a water lover, I don't like tea, but everybody got their preferences. That person is going to adapt to to the patient's, the resident's preference, right? You're going to have improved satisfaction. You're going to have improved family satisfaction. Think about it. They're going to go out there and say, guess what? At that place, they have somebody there to make sure. You know, those lawyers, when I was doing my research, these firms have all that information on their website about dehydration. And they're calling you to call them if you know your loved one is not being hydrated because they want to sue. You're going to decrease your exposure. Okay, if you have a hydration CNA. And if you tell people that you have it, think of the marketing pool that you're going to have. Who else is doing that? You're going to stand out, right? And then I said, you're going to have expected staff modeling because if that person is the right person and she's talking to the rest of the staff and the rest of the staff is watching her interact, offer fluid, worry about, you know, whether they're eating or drinking, it's like by osmosis, they're going to absorb, they're going to model some of that behavior. Now, how do you put a money value to that? To the rest of your staff, seeing how this hydration queen is dealing with your residents, and they're going to want to do the same. They want to do the same. I'm telling you, it's going to happen. And then you're going to ultimately improve your rate of rehospitalization. As I said, dehydration is involved in increased UTI admissions, falls, confusion, pneumonia. Oh my gosh, what have you got to lose? And I know it's difficult that some um, of your regionals or your ED, they're probably going to say, we don't have the fund, but you have got to be an advocate. This is why I say nurse training and advocacy. You have to advocate for you so you can meet your goals, get your bonus. You're going to advocate for your patient, your residents, because you want to improve their outcome. You want to advocate for your staff because I think once you create a culture of caring, where they see that you care about the patient and you're going to invest in something as simple as offering fluid, making sure people are hydrated, they're going to say, oh my God, my job, they care for my resident. You're going to decrease burnout. You're going to decrease the rate of staff dissatisfaction. As you know, that is a big part of why they're exiting. People just feel like nobody cares about the patient. They don't care about them. Isn't it time that we start doing things a little bit differently? Okay. And then you may have other staff members show interest and say, oh, I'd like to do that. Maybe you're going to have somebody else that says, oh, when so and so is off, you want to have a backup, right? Let's do it. Do it. And if things start looking good, give him an incentive. Maybe you're going to attach a little bonus to outcome measures based on those interventions. Why not? So I've gone to my 30 minutes. If you are interested, if you are a facility and you're willing to be involved in this research project, I'm open. I'm writing an article, and then I could tag on research would be another article we can write at the end of the monitoring process. So if you would be interested, if you have a way of implementing this, and I can give you more details about how to do that, call me so that I can come look at your numbers I can look back maybe 6 months. Then we're going to implement. I can teach you how to hire this person. You're going to have to do some motivational hiring. You're just not going to hire because they have CNA after their name. They have to have certain personality and character trait to do this job well. It's not just somebody who's just looking to do 8 hours and rush out and not worried about anything else. Mm-mm. So contact me. This is my email. I'd love to talk to you more about this, but this is my proposal. And I hope I'm not the lone voice in the desert that some I'm not in a facility right now. So I don't have any pull as to, you know, how we can do this. But I'm saying a CNA, that's the lowest paid employee in your facility because I know kitchen and all that they contracted. So let's find a way to fund one position and then see all the impact that you might have. Try it for 6 months. What have you got to lose? What have you got to lose? Everything else you're doing, you're still struggling. How about implementing this? And then see. If after 6 months you don't have any change, you could say, well, Maggie, it didn't work. I'm not a liar, but there is nobody looking at this particular model at this point doing this in long term care. Like I said, you see through the research, everybody's doing this, doing that, doing that. How about not something else? Or if nobody, I mean, I'm going to make some calls. I'm going to see if anybody is, I'm going to reach out to some people, whether they might be not here, maybe they be in Canada, but I would love for them to be here in the US. But if that's not the case, we can find them somewhere else. All right. So I think this is it. Oh, you know what? This was supposed to be earlier in another, maybe the first slide. It's kind of backwards. No standard definition. This is how we measure it now, and there is no standardization. Yeah, I got to change that and put it in the beginning of the slide. But anyway, you got my point. And I am so glad that I realized that this thing did not record and I can do it. I know I have to go meet my family now, but um, I'm so glad you kind of joined and you listened to me. And hopefully, I'm not just babbling, that this particular topic is of interest to you. And like I said, I noticed there was some interest in the previous presentation. I am going to post this before I leave on Facebook and YouTube. And hopefully, you can share it with your staff. Have your managers look at it and see if they will buy into the idea of implementing a hydration CNA. Please do it, do it, do it, do it. Do it for your patients. All right. Thank you so much for joining me. I will see you next week. And God bless. Au revoir. À la prochaine. Ah, I usually do that with my other channel. Oh, that's not very professional. Au revoir. Sorry, guys. Yes, I